and you can take it away.
Hello, everyone. We want to introduce you or invite you to participate today in our Symptom Control and Quality of Life Committee meeting. My name is Lynn Henry. I am here today with my co-chair, Mike Fish, as well as other members of our committee, including those who play an active role that we'll introduce you to later, as well as folks who are either conducting trials right now or who are proposed potential studies within our committee structure. So thank you very much for taking the time to be with us today. Next slide. These are just our brief disclosures. Next slide. So wanted to just go over the agenda. We have a fairly busy agenda today. We're going to start out with some basic announcements, let you know about the committee for those of you who haven't participated here before. And then most importantly, we have our special symposium this morning. So it's going to be on wearables and symptom research for patients with cancer. And we have two esteemed colleagues joining us today to give presentations, and then we'll follow that up with a panel discussion. Following that, we're going to talk about some new concepts that are in the works. We're going to give you updates about our activated trials and the ones that are currently on hold. And then finish out with some just additional business, and everyone can get on with their day. So again, we want to thank you for coming. Next slide. Brief announcements. There's really two. One is really important, and unfortunately we always say this one at the beginning of the meeting when not everyone might have joined us yet, but we are very interested in new ideas for concepts. And so whether you are a medical oncologist, a hematologist, a basic scientist, epidemiologist, a statistician, an oncology research nurse, anyone across the whole spectrum of people who are interested in symptom management and quality of life, we really want to know you're out there. We want you to let us know what topics you're interested in, what diseases you're interested in. And definitely, if you have an idea for a pilot grant, for a pilot proposal, or for a full-fledged clinical trial that we can run through SWOG, we definitely want to hear from you. So feel free to contact us either through chat or, more importantly, after the meeting, so we can connect and learn more about you. Next slide. The other thing I just wanted to highlight on, for those of you who were just at the plenary, you already heard this from Lee Ellis, but Hope Foundation for Cancer Research, we are greatly in their debt for supporting a lot of what we do here in SWOG. And so I want to encourage everyone to donate to the Hope Foundation so that we can conduct even more exciting research, but it's also what they can do for us. And so there's research support that you as individuals can apply for. The two I wanted to highlight that are coming up are the Hope Impact Award, which is a larger type of grant up to $250,000, specifically for looking at either findings that have come from SWOG, trying to bring those forward into learn more about mechanistic processes, for example, or ideas that you want to in the future bring to SWOG, so it can be used either way. And then the second thing is the seed grants, which are really helpful for trying to conduct pilot studies that will enable the conduct of future SWOG trials. Those both have deadlines of July 1st. Then there are other things sort of in the background that are available all the time. A very important one is secondary data analysis. So if people have ideas about looking at previously collected patient-reported outcomes or looking at previously collected samples on SWOG trials, this will provide some funding, especially for the statistical support, to be able to do some of those analyses. Next slide. And then in terms of career development, SWOG and the Hope Foundation do a lot in that respect as well. There is a grant writing workshop that is coming up. The deadline is May 1st, and the workshop itself takes place virtually over the summer. This has been going on for many years and has been quite successful. And then there's also the Young Investigator Training Course for people who actually have concepts that are in the works or have been supported by the various committees. That deadline is May 14th. And you can learn more about these on the SWOG website. There are other grants available for junior faculty, for mid-career faculty, and for statisticians that you can see listed here. And as I said, everything is available on the Hope Foundation website, so please check it out. Next slide. Now I will turn it over to Dr. Fish.
Development and implementation of clinical trials that create new understanding of the mechanisms of symptoms and new methods to reduce patient suffering. And so we're multidisciplinary. You'll find that our committee includes medical oncologists, radiation oncology, representation from surgery, nursing. We have some basic scientists from across different fields, as well as patient advocates, biostatisticians, epidemiologists. So it's a big tent, and it's not even limited just to these disciplines. And part of our special symposium today is to get outside of these cancer-focused areas and include perspectives from other realms of research and chronic illness. And really, one of the strengths of our committee is participation of young investigators and a very strong NCORE network with community oncologists and researchers. Next. So we measure success in terms of our research production as well as process excellence. On the production side, really all these things are hard, and we work hard at them, ranging from ideation to study development, launching the trials, executing them, including accruing at the right pace, analyzing the data, publishing our data, and then making good use of the data that we have with secondary publications and other projects. Process excellence starts with prioritizing the work that we choose to take on so that we have the maximum impact, keeping a multidisciplinary focus and a focus on young investigators and being diverse and inclusive. Next. We have priority topics and methods, and certainly our work is not limited to these particular topics or methods, but this does reflect where we have established some momentum to this point. Clinically, that includes in the realm of chemotherapy-induced neuropathy, immunotherapy toxicity, and aromatase inhibitor toxicity. Methodologically, prospective cohort studies is in our wheelhouse, and we are interested in digital health interventions and behavioral and integrative medicine interventions as well. Next. Our committee leadership is shown here on this slide. Our executive officer is Gary Lyman, Dr. Gary Lyman. Dr. Henry and I are the co-chairs. Our statistics team is led by Dr. Joe Unger, and Reha Vaidya and Celine Jones play a key role as well in our statistical work, particularly with patient-reported outcomes. Our patient advocate is Amy Geschwender, and she is out due to family issues, and so not at this meeting, but we're getting good support from Rick Bangs and the patient advocate community in her absence. And our clinical trials project manager is Crystal Miwa, and our protocol coordinator is Sunny Tinsley. So it takes a village for sure. Next slide. Well, so we are, we'd like to start now with our special symposium, and that special symposium is on the use of wearables in cancer research. And in this symposium, our focus is going to be to look at both the perspective of cancer care with Bill Wood, who's a physician and researcher from the University of North Carolina, and also the perspective of chronic illness outside of cancer. And our guest, our plenary speaker there is Dr. Paolo Bonato, who's a PhD researcher. So we're going to have each of our speakers speak in sequence, and then we're going to have a panel discussion to go over things. Now, for a few minutes, I know that Dr. Wood was having some trouble getting logged in onto the WebEx with a special VIP password that we gave him. So I don't know for sure whether he has been able to get in. Does anybody know on our panel whether Dr. Wood was able to log in yet?
He's not logged in quite yet, but we have sent him the information. He should be logged in shortly.
Okay. Well, so I think what we can do, maybe we can just reverse the order. If Dr. Bonato, are you available to do the first
Not a problem at all.
Okay.
I
So
work in a hospital, so you have to jump in, right?
That's
when there is
right.
a need, right?
We will do it in that order. Let me introduce you. So Dr. Bonato is associate professor in the Department of Physical Medicine and Rehabilitation at Harvard Medical School. He's also an adjunct professor of biomedical engineering at Harvard. He works with the Wyss Institute for Biologically Inspired Engineering at Harvard, and he's the director of the Motion Analysis Lab at the Spaulding Rehab Hospital. So we're delighted to have you, and we thank you for your generous participation in our symposium.
Thank you very much for the kind introduction. And I was wondering if the IT tech bill could just move to my first slide and then give me control of the slides so that we can start from there. But, as we're doing that, I wanted to thank Michael and Lynn for their kind invitation. It's really a pleasure to work to talk to this group. I'll share with you some of our experiences with the use of wearable sensing technology in the field of rehabilitation medicine. I know that many of my colleagues have a specific interest for the application of these technologies to your area of work. I tend to focus on conditions such as stroke and traumatic brain injury. And as an example of application of this technology, this is actually what I'm going to tell you a bit about today. But I trust that it will be very easy for you to envision how that translates into your own work. So these are my financial and non-financial disclosures. My financial disclosures are primarily related to grants that I have received from several federal agencies as well as foundations. I typically don't do consultant work. I've done just recently a service on the advisory board of Swan Bio, which I've discontinued recently, but everything else actually goes through my department, including my volunteer work in a number of advisory boards, which I do pro bono. I just do it as an uncompensated role to avoid conflicts of interest with my role here at the hospital, which is focused on serving as a reference and a testing laboratory for technologies that we want to integrate in our clinical program. So I will be talking to you a bit about the use of digital health technology in the context of rehabilitation medicine. But before we get there, let me just tell you a couple of things quickly on the technology that I'm going to discuss and the one that we're using both in our studies and now also in some of our clinical services. I've been working in this area as a researcher for 22 years. I received my first grant in 1999 when I was at Boston University. So I celebrated a couple of years ago my 20th anniversary of work in this area. And back in those days, myself as an engineer and my team, we actually had to build things from scratch because there was no wearable. And when we presented our work at meetings, conferences, and our clinical teams, we actually had to explain what this is. Of course, this is absolutely no longer the case, but because people are really familiar with consumer electronics and all sorts of gadgets that you see on the screen at the moment, and because thanks to the fact that there has been such a strong interest in the private sector for the development of this technology, we really don't have to develop much in-house at all. And so we're now actually using off-the-shelf systems. So if we want to monitor cardiovascular functions or individuals with chronic obstructive pulmonary disease, for instance, if we go down pulmonary, which is work that we have done here in Boston with Marilyn Moy, who's in charge of the cardiopulmonary program at the VA hospitals, but in Jamaica Plain as well as in West Roxbury here in the Boston area. So now we're actually using off-the-shelf systems. And you're probably familiar with the fact that you don't just get any longer a respiratory rate or respiration rate and heart rate, but you can actually get as much as oxygen saturation from these sensors with various level of accuracy and reliability. For instance, Unfortunately, the latest version of the Apple Watch has come up with a AutoSat sensor, but unfortunately, the data that you gather with that type of sensing technology appears to be still of limited reliability. In fact, some of the other vendors, including Fitbit and a company we work with, Alert Health, which used to be called Jawbone, actually have developed sort of alternative ways to implement their sensing technology for that purpose. So I'm mentioning it as sort of a warning indication that as much as we love to use these off-the-shelf technology, we always have to assess carefully the accuracy of the data that we're collecting with this type of off-the-shelf sensors. We're interested in galvanic skin response as part of the analysis that we run in data collected from patients with autonomic dysfunctions. You know, galvanic skin response, for instance, is utilized not just by the industry, the advertisement industry that looks into emotional responses to different types of messages, but also, for instance, by researchers here in Boston at MIT who have explored the use of changes in skin conductivity that are associated with the occurrence of seizures in individuals with epilepsy. So there are a number of different applications of this technology, and what you see on the screen are different systems that have been proposed in the past, and are some of them still commercially available. For instance, the Empatica system, which is a device developed by a spin-off company of the group at MIT that I was mentioning, is commercially available and something that we're actually using in some of our clinical trials at the moment. As rehab scientists, we're interested in movement, of course, and so we're interested both in deriving what we call the kinetics of motion by looking at interactions with the floor, ground reaction forces, and then estimate the forces and torques generated by muscles at different joints, as well as we're interested in deriving movement patterns from sensors that we strap to different body segments and that allow us to reconstruct the trajectory of movements, and therefore things such as assessing range of motion and angular displacements during movements, as well as technology, which it's what you see on the right side of the screen, that allows us to monitor the activity of muscles. What's available out there as wearable at the moment, not very selective, right? Meaning that, as you can see on the right side, there are a few companies that are embedding essentially electrodes in undergarments, but given the interelectrode distance, what we're getting are basically gross activities of groups of muscles, such as, you know, in this case, the elbow flexors versus the extensors, as opposed to have the capability of detecting the activity of specific muscles of the forearm, for instance, that given their proximity and given the geometry of the anatomy are difficult to tell apart. We're also interested in the activity of the brain, of course, right? And so I mentioned earlier stroke and traumatic brain injury. It's obvious that we're interested in this technology. And besides the work that we do in the laboratory with electrode arrays, there is now the opportunity through new technologies that are essentially boil-down systems of electrode array systems that we're using in the laboratory to monitor individuals in the field. And there are promising new technologies such as near-infrared that we're looking into as a way to monitor individuals during the rehabilitation session, so the interventions in our gyms, right, in our physical therapy and occupational therapy programs. So why are we interested in monitoring individuals in the field? Because what we do is we attempt to gather information to develop patient-specific interventions and adjust them over time. So our discipline is a bit younger than yours. And so we are about I often tell people we're kind of naive to the field, right? And so to the lay person, and they come through our hospital to visit with our development office. So what do? I tell them that we are where you guys were 30 years ago, right? And of course, for you, prescribing the same intervention would be illegal at the moment, right? So if you have two patients and you don't phenotype individuals and you don't personalize the intervention, you would likely go to jail, I would assume, right? And so that would be considered absolutely unacceptable from a professional point of view. In the field of rehabilitation, we're actually developing those tools. And those include both the motor phenotyping that we do with sensing technology and the actual phenotype of individuals. For instance, we're looking into genotypes that are associated with dopamine deficiencies, right? This is something that's new in our field, but that's the direction in which we're going. And that's the reason why we want to gather quantitative data about the response of our patients to a variety of different interventions that we're setting in place so that we can choose the most suitable intervention on a patient-by-patient basis. And these complex process, we call it precision rehabilitation interventions. So what we do with the technology that allows us to collect data in the field, we do primarily three things, right? And so we put our projects in three big buckets, right? And so the first one is one in which we monitor activities. For instance, in individuals with chronic obstructive pulmonary disease, we look at systemic responses associated with equally demanding motor tasks in an attempt to predict exacerbation episodes. We started doing this work about 15 years ago, and there's been a lot of progress in this field for the purpose of achieving early detection of exacerbation episodes. And this is an audience that I don't need to explain why this is so relevant in the management of this patient population. In the population of patients that I mostly focus my work on, stroke, we look at quality of movements instead. Right? We're not necessarily interested purely into monitoring activities. I'll tell you in a second that we're interested into it as well, but our primary focus is on assessing changes in severity of impairments and functional limitations and quality of movements that are observed in response to our interventions in our physical therapy and occupational therapy program. And so I will elaborate on applications in stroke just in a few minutes. The third thing, or the first bucket of projects that we have, is a bucket of projects in which we use wearable technology to feedback information to mobility assistive devices. These I don't think it is of specific interest to this group, but I wanted to mention because there might be applications that are just not aware of that might be of your interest. And this, of course, is very relevant in rehabilitation because unfortunately we did with individuals with chronic conditions, and at some point in time, unfortunately, we get them to a plateau and we need to figure out what we do from a functional point of view in these individuals. And so mobility assisted devices and all sorts of assistive technologies, they tremendously benefit from wearable technology as a source of information to better drive the robotic technology, for instance, that we utilize to improve mobility in these individuals. So let me provide you with a case in point here and focus on individuals with hemiparesis, whether this is related to stroke or traumatic brain injury. We really utilize both the same clinical scales, right? So we're going to use a Fugl-Meyer assessment for impairments. We use a Wolf motor function test for function. We use a functional ability scale for quality of movement, irrespective of the population, as long as it has the motor phenotype that I mentioned. And again, I don't need to tell this audience how relevant it is to focus on this population. It's clear that the numbers of individuals that suffer stroke, unfortunately, is quite large. We have about 800,000 individuals who suffer stroke annually in the US alone. We have a large portion of these individuals, about 70-75% of the individuals who survive a stroke, which are now luckily the great majority of the individuals that suffer a stroke, close to 700,000 a year, right? So about 70-75% of those individuals, they do display residual motor impairments, 6 months plus, right? So which is where we consider patients to actually make the transition to the chronic phase. And in the earlier phases, but even in the chronic phases, when the patient's characteristics indicate that there might be a positive response to an intervention, we have a variety of different techniques that we use to restore motor abilities in these individuals that span from constrained use movement therapy, which is essentially forcing the use of the hemiparetic side of the body, for instance, in stroke, the stroke affected side of the body, to the use of robotics in individuals that have very severe impairments and lack the ability or have tremendous difficulties moving or generating movement patterns with the stroke affected limb or the hemiparetic limb in general for individuals with traumatic brain injury. So we have all sorts of different types of interventions. And what we want to do, as I mentioned earlier, is to track the response of each individual patient to an intervention and then periodically revisit what we're doing on an individual basis on the basis of quantitative measures, on the basis of outcomes that we're gathering using this technology. And why do we want to use it using technology as opposed to assess individuals? Because as I trust the great majority of you know, if we want to assess motor impairments and functional limitations in individuals, we need to schedule a session about an hour, 60 to 90 minutes long. And I would assume the great majority of the audience here has a clinical background. You work with patients in the clinic, you just cannot afford 90 minutes a week to assess an individual, right? And so unfortunately, unless there is a tremendous impact that you're going to have with that type of assessment on a case-by-case basis, right? So as rehab specialists, we're not there as yet, meaning that, as I mentioned earlier, we're still a young discipline from many points of view. And we're still in the process, in my opinion, of figuring out how to leverage the information that we're gathering through quantitative assessments, for instance, of motor abilities of individuals. Of course, we do things that go beyond motor, but today I'm actually talking about motor impairments, right? But because we're still in the early phases of developing these techniques, it's very difficult to justify and obtain reimbursement for a 90-minute session of assessment per week. And honestly, in my hospital, we wouldn't have the personnel, right? And so, and we're ranked #2 in the country. I doubt that the other hospitals are in a different shape, right? And so, and in fact, every time I talk to folks in other rehab facilities, they are exactly in the same type of situation and exactly like we do focus on the use of this technology to gather this information. They're pursuing it themselves. So there are a number of researchers that have proposed various techniques to start looking into, for instance, whether subjects are actually using actively their stroke-affected limb, right? As I mentioned, this applies to a variety of conditions associated with hemiparesis. Just for the simplicity's sake, I'll talk about stroke, right? So that I don't repeat these multiple times. This is work by Catherine Lang at University of Washington, St. Louis. She, as a few years ago, she started experimenting with essentially strapping two activity monitors to the right and left limb. And the overall objective is the aim of achieving the equivalent of a motor activity log. And for those of you who are not familiar with that scale, what we essentially do is that through self-reports, we gather data related to amount and quality of use of the stroke-affected limb. The reports are very unreliable, as you can easily imagine. And we have, like many others in our field, we have demonstrated that that's the case, right? And in fact, just for curiosity, we have looked into the association between the attitude of the individual toward the intervention, the motor activity log and the outcomes, and the correlation between the attitude of the individual and the motor activity log is extremely high, whereas the correlation between attitude and the motor gains, it's not as high, right? And so this is really a scale that through self-reports, it primarily reflects, to be honest, the attitude of the patients toward the intervention, the level of enthusiasm, etc. Right? And so Catherine, like many others in the field, thought, well, what if we actually use sensors on the two limbs and design indices that are replacements or they complement the motor activity log that actually allow us to capture amount and quality of use. And in this case, in the plots that you see on the right side of the screen, the focus is on amount of use. And you can see the different plots from the top to the bottom. And the plots on the top relate to individuals with more severe impairments, the one on the bottom. And you can see that the plots, without telling you all the details about how the plots are pulled together, they are skewed. They're basically skewed on the left side for the patients on top, and they are more symmetric for the patients on the bottom. And the skewness represents the imbalance between the use of the stroke affected and the contralateral side. And so on the left side, we have the contralateral limb. On the right side, we have the stroke affected limb. And you see the activity on the plots on top that's actually moving on the left side of the of the plots, right? And that represents the primary use during the performance of activities of daily living of this contralateral limb as opposed to the stroke affected limb, which I trust many of you know it's associated with what we call learn on use. So remapping essentially of cortical areas that are going to be lost from a motor recovery point of view, right? So remapping into functions, they're not necessarily the ones that we want to remap because the subject is actually not using the stroke affected limb. So the technique
Dr. Bonato, I just want to give you the 3-minute warning here, just to keep track of time. Yeah.
I'll be quick, right? So in fact, you know what? I'm actually going to stop at some point so that we don't steal Bill's time. I noticed that he is now on the WebEx, right? So the technique that Catherine Lang proposes some limitations because his sensors are on the wrist. In the more high functioning patients, we're actually interested in looking at manipulation. So a former student of mine actually started some work using sensors that are now in the form factor of a ring, like the Aura ring, but in this case, for the purpose of detecting movements. And this has been expanded by some of my other associates to a variety of different clinical scales. So this is work done by Dr. Adan Dester in my laboratory that we published in Nature Digital Medicine last year, in which we look into essentially using wearable to monitor in function, impairment, and quality of movement, essentially estimating clinical scales that capture these different dimensions. So I'll skip a couple of slides here because I don't think they're necessary. And, you know, just giving you the sort of the meat of it, right? And so this is work that we started with focus on quality of movement 10 years ago. And this is work that we published in a technical journal to show that we can predict with good accuracy the functional ability scale score. And you can tell that that's the case because on the vertical axis here, we have the clinical scores generated via visual observations of the patterns of movements of individuals. And on the x-axis, we have the scores estimated using wearable technology and machine learning techniques that we developed back then. The project was led by a former student of mine, Shama Patel, who is now the Chief Science Officer at Aura. And you can see the data sitting on a line, and engineers are always very happy when things are on the line. It means that the estimates that you get are really reliable. They're basically the same that you would get clinically. And as I mentioned earlier, Dr. Adandester has expanded these to other functional measures, right? And so I'll skip again a couple of slides to close quickly. I'm sorry I spent a bit too much time on my previous slides. I just wanted to say this technology, we can use it also to develop interventions in the field, right? And so it's clear that we have access to patients in our clinic for a limited amount of time. What if we use the technology now to monitor them? And for instance, if we want to encourage the use of the stroke-affected limb, can we monitor their activities in the field and buzz them, provide them with all sorts of reminders through mobile applications and things of that nature? This is an idea that NIH liked, and so they sponsor us together with a spin-off on Northeastern University here in Boston. The project has been was led originally by George Ewing, and we continue to actually work on this project at the moment with very encouraging preliminary results. But there is a lot out there in terms of sensing technology and companies interested in running exercise routines in the home setting using these technologies. And this is one of the companies that got a lot of visibility out there because they got large investments. And we're looking into also solutions that don't rely necessarily on wearable, but purely on the use of image processing techniques. So as opposed to run a telemedicine or tele-rehab session by using the sensors and getting the sensor data streamed to your clinic, you can just get into a video conference and then do tracking essentially of the movements, be it this sort of skeleton representation of the patients going through exercises, and monitor their exercise remotely. So this is truly what I wanted to say. This is my team in the lab, and this is my contact information. And again, apologies for taking a bit longer than I should have, and I'll pass the baton to Bill for the other talk. Thank you very much.
Yes, thank you. Thank you so much, Dr. Bonato. That's fascinating, and it's a different perspective than we're used to. And so great. Our next speaker is Dr. Bill Wood from the University of North Carolina, where he's Associate Professor of Medicine in the Department of Hematology. His clinical and clinical research work is focused on blood cancers, particularly hematopoietic stem cell transplants and cellular therapies. And he has a lot of research focus and knowledge about the use of wearables and digital biomarkers. And Bill, I know that it's taken some time for you to sort of get lifted into the meeting, and thanks for your persistence and welcome.
Hi, everyone. It's a pleasure to join, and it's been great to listen to your talk, Dr. Bonato. Perhaps you'll see as we move along where perhaps we should work together. And I'm sure there are going to be lots of great ideas that will come out of this symposium, and thank you for organizing, Dr. Fish, Dr. Henry. So I don't think I'm controlling my slides, and that's probably fine. We can just sort of, I'll just say next, I guess, if that works. Okay, perfect. And I'll try to do my best to kind of make up some time. So I might go a little quick, and if you want to circle back and talk about anything that I've discussed, we could definitely do that during the panel discussion afterwards. So why don't we go ahead to the next slide? Okay, next. So I wanted to start by talking a little bit about patient-reported outcomes and patient-generated health data in the context in which I think many on this committee are very familiar. And then I'll use that as a jumping off point to talk about a program that I've been working on locally, sort of a different way of looking at integrating PROs and patient-generated health data and potential development of digital biomarkers to improve the care of cancer patient survivors and maybe even caregivers. But this is a usual context, I think, that that you're familiar with, in which a patient, a cancer patient, connects with a electronic patient-reported outcomes system, and that then feeds into either some type of a unique patient portal, maybe even the EHR, though that's its own very different and complicated implementation talk. Subsequently, alerts are generated from the PRO that the patient has filled out, might relate to a symptom score, for example, quality of life, functional domains. Reports are generated, and then those end up going to members of the clinical care delivery team, who can then look at that information and circle back with the patient to potentially address symptom needs or other issues, potentially adjusting cancer dose therapies. And the idea here is that perhaps this is information that's not routinely captured in clinical care that can improve cancer outcomes. Next. And now there are a variety of ways and tools that have been developed to capture this information, both in the setting of clinical trials and also usual care. Web-based systems are available. These have been adapted for mobile uses. Increasingly, interactive voice response systems are also used for those who don't prefer to interact in a web-based way. Next slide. And to the point, I think this is sort of just where the field is beginning to evolve. We're trying to figure out sort of how patient-generated health data coming from increasingly consumer wearable technologies, or perhaps ones that have been developed specifically for this setting, and those are emerging now as well, can complement the PRO data to provide a more full picture of cancer patient experience and then guide clinical interventions. Next. Data from examination of systems like this suggests that patients and care providers find this information easy to understand and to work with. Next. And these are nurse impressions of a system that's very similar to that was developed by Ethan Bash and colleagues. Ethan is a colleague of mine here at UNC, and so I've been very lucky to benefit from his guidance and mentorship as he has continued to expand his PRO platforms across different care delivery settings. Next. And I will actually go to the next slide so we can move along. I think many of you are familiar with the STAR randomized controlled trials as presented at ASCO now a couple of years ago. But the bottom line is that the system that I've described is essentially deployed among patients with advanced cancer who weekly reported self-reported common cancer symptoms. Reports were generated, alerts were sent, interventions were done, and then outcomes were explored. Next slide. What they reported was strong adherence throughout the study. These are adherence rates to patients who continue to self-report their symptoms weeks into enrollment. These were individuals, many of whom were older, had advanced cancer, may not have been technology literate or particularly savvy. Next. And what they found was that quality of life was improved in the intervention arm, those who did the self-reporting of symptoms. Next. Emergency room visits were reduced over the course of the study. Next. And overall survival actually was improved, with the intervention group having an average overall survival of 5.2 months longer than those in the control group. Next. Ethan and colleagues hypothesized several different mechanisms of action, and as this is not the setting of the intervention that I'll describe in just a moment, I won't spend a lot of time on this. These are discussion points at the ASCO plenary and also presented in subsequent publications. But one of the ideas was that this technology helped to facilitate earlier interventions, allowed patients to stay more functional, and perhaps allowed for finer tuning of chemotherapy prescriptions. Next slide. Subsequent work has essentially validated these findings with similar systems in a large French lung cancer randomized controlled trial. Next. And similar work has been ongoing in Canada as well, showing again benefits to doing self-reporting of symptoms and functional status. Next. So the question that I and my colleagues asked was about whether we could use this type of self-reporting technology and consider other frameworks within which to implement this in oncology care settings. And I'll describe a few principles that guided our development of a subsequent intervention. We also were looking to find ways to very pragmatically integrate sensor data with PROs. And I think while I would certainly love to, in the next generation of this, get to some of the newer technologies and newer digital biomarker development that Dr. Bonanno described, we started fairly simply with standard Fitbits, and you'll see that how we can potentially build off the back of that intervention. And then we discussed as a group whether there were other models for implementing the intervention that were a little bit different than the standard tightly integrated with care delivery model that Ethan and colleagues have been working on for some time. Next slide. And so what we came up with by way of basic principles was to reframe the way that we were looking at health in persons and caregivers impacted by cancer. Next. So just a few key principles that kind of underlie how we came up with a program that is a cancer coaching program, which I'll describe in just a few slides. The first of these principles is that cancer care, like healthcare generally, is illness-oriented and reactive. We spend a lot of time fixing problems. And so what we really wanted to spend some time focusing on was how we could think about health as a construct that could be optimized as opposed to continuing to think about problems that popped up to be fixed. Next slide. We recognize that if we were focused exclusively on problems to be fixed, we potentially were losing opportunities to address upstream determinants of health. We also hypothesized that by focusing on health as a construct to be optimized, we could potentially prevent or reduce the impacts of illness and ultimately help to intervene and influence decisions that can integrate values and preferences oriented towards optimal health rather than fixing problems. Next slide. And in thinking about optimizing health, we recognize that individuals have different perspectives of their health and that health is multidimensional. And so if you think about the different domains that go into quality of life assessments, that's one way of looking at the dimensions of health. Other ways are to look at other aspects of health that can be addressed in various ways, including physical activity, nutrition, sleep, and others. Next. Another key principle is that when we think about optimizing health, we recognize that health is truly centered at home and not the clinic or hospital. Our interactions with patients have a certain perspective to them that is really through our eyes as providers. But when patients are thinking about how they're optimizing their own health, they're not thinking about their experience within the clinic or the hospital, and that's something that we should remain focused on. Next slide. And a key hypothesis here is also that optimizing health can then come back and have beneficial impact upon experience and outcome of illness. And that's what allows us to think about how we can come up with an intervention that really is clinically integrated. So otherwise, we're sort of off in the realm of being maybe a Fitbit or an Apple Coach. But really the intent here is to think about how optimizing health can come back and positively impact areas like symptom management, acute care utilization, and other outcomes that are important to us as clinicians. Next slide. Finally, central to our vision of health optimization was a focus on physical function, understanding that physical function is critical to help patients to perform activities of daily living at home, undergirding other parts of their vision of optimal health. Physical function is affected by cancer and cancer treatment, and we know that it's directly related to morbidity, mortality, and quality of life through the concept of performance status, which we measure all the time in clinic. Next slide. And so what we wanted to do is come up with a new approach that was health-oriented, and what we ended up developing was a health coaching program that we're calling Health Score. These slides are kind of moving along, which is great because I need to kind of stay on track anyway. What we developed was a health-oriented coaching program intended to reduce the impact of cancer upon patients and caregivers. And I think what you'll see through this example is one way in which we are directly integrating PROs and data from sensors to impact the way that we are delivering interventions to patients affected by cancer. Next slide. Next. So the program that we have, what we ended up coming up with was something that was fully virtual. We actually relaunched our program right in the middle of the COVID pandemic, so we needed to find a way to reach patients while minimizing interactions within the clinics. And we ended up moving our consenting to fully virtual, as well as all activities, including home-based assessments of physical and cognitive function, in addition to PRO assessments and activity tracking through the wearable sensors. We wanted to make sure that we included symptom monitoring because we recognize that this is a key function undergirding the success of other PRO programs. Our intent was to personalize this to the needs of individual patients who went through the program. We developed a coaching curriculum, we'll talk about that in just a moment, by which coaches connected with patients each week for a total of the 6 months of the intervention. And then importantly, we wanted to integrate the program with other services delivered through the cancer hospital. And this is really the link that we use to look at the responses to the PROs and the data coming in for the activity trackers, and then to determine which services we could target towards patients to help optimize health in a way that was essentially a version of a navigation program. Next slide. So in each week, when our coaches are connecting with patients, and these are patients who could have any type of cancer and anywhere along their cancer treatment trajectory. So most of our patients are undergoing active treatment, but we definitely had some patients that were finishing active treatment and moving into survivorship as well. And each week, the coaches were actually looking at the data coming in from the PROs and the Fitbits, and then they were working with patients in a personally tailored way to look at the different domains of health, to help patients with prioritization according to their own values and preferences, and then to set goals that could carry over to the next week. Then the process would iteratively repeat itself week over week. Next slide. When we think about our different health domains, these are the areas in which we have developed a curriculum and we're actively intervening with patients. So we're working on symptom management. We're addressing issues related to social support, nutrition, physical activity, and remote monitoring. And we use this through the sensor data that we're getting in, spirituality, quality of life, sleep. And then importantly, we also have a focus on treatment goals and agenda setting. So we are we're not directly in the EHR, but we have access to the EHR. And so we put reports in the EHR through the progress notes. We're also looking at what's happening in the individual's care, and we are helping the individuals think about how they want to approach their subsequent visits with their care providers, and also leaving notes in the chart that can help care providers see where the participants are with regard to their own health journey. Next slide. So the data that come in to inform what we're doing are coming directly from the sensors, from the PROs, and then also from notes the coaches are taking during their calls each week. Next slide. And we take those data, and as I had hinted at before, these data then are used to inform navigation to other services. So we can take the PROs and we can actually go right back to the coach and the patient to provide ways in which non-prescriptive interventions might optimize health and the symptom experience. We can escalate to, and we do, to APPs, nurses and physicians if there are acute care needs. And then we have discrete pathways that we built out with the various programs around the cancer centers. We have pathways towards our pharmacy group for adherence around oral anti-cancer therapies. We have pathways for the types of patients that are best suited for integration with our palliative care program. We identify patients who might benefit from psycho-oncology supportive services, those who would benefit from chronic pain management. This actually was a need that our palliative care colleagues helped us identify as one in which they thought that there might be another group that was optimally suited for chronic pain management. So we've worked with them to develop that connection and other supportive resources as well. Next slide. We built a web-based dashboard and a portal that both participants and providers can log into, where they can actually see goals over time. Because we think that physical function is central component to optimal health, we actually have a fairly well-developed curriculum around aerobic and resistance exercises at home. We have some training videos that patients can see in terms of what is individually prescribed to them based on where they are and what they've done the previous week. They can look at their symptoms over time. We track symptom burden. We track physical function over time. And then we have a variety of other pages that help direct participants to resources and other self-directed learning. Next slide. And any of these areas can be drilled down for more detailed visualizations. We'll keep moving in the interest of time. Next slide. And then, as I mentioned before, what we ended up doing, and this is actually kind of a couple screen grab, cut and paste. It's not the way the actual report looks, but what we have each week for any given participant is we're able to actually use the PRO data and the sensor data to provide sort of week over week tracking. So we track physical function over time. That's what we're calling our health score. We use a promise tool for that. And Dr. Bonato, I'd love to actually develop a digital biomarker that one day will substitute for what we're calling our health score currently. We track the activity data from the sensors over time, both in terms of volume and active minutes. And then we have notes from the coaches. What I'm not showing you here is we actually have detailed symptom burden and individual symptom graphs that track over time as well. I just couldn't fit that into this slide. Next slide. And I should have mentioned as well that on top of that report, as you are probably familiar with Epic or other systems, you can put attestations on notes. So the notes get actually routed to me at this point, and I will actually provide sort of a high-level summary, and then I'll put that in the chart in terms of the types of, just high-level bullets that I think that other providers interacting with the patient may want to take from that report. They can always go down to the details if they'd like to, if they want to learn more. Next slide. So what these data allow us to do over time then is to also provide a visualization using the PROs and the sensor data that reflect the patient journey and patient experience. And so I'll show you two of these graphs in just a moment. But what this is showing you is physical function over time for a given participant who's on a program who has breast cancer, has been treated with chemotherapy and radiation. And you're also seeing a total symptom burden score. So we actually obtain individual symptom scores from the pro-CTCAE and sum them over time to come up with a symptom burden score. That's the middle figure, and then we have activity in the lower line. Next slide. What we see, for example, when we look at physical function over time, is we can actually see peaks and valleys. Higher is better for the score that correspond with clinical events that's occurring in the patient's care trajectory, whether on or off radiation or chemotherapy, for example. And so we think that these readouts actually are correlating reasonably well with what's happening clinically. Next slide. And the same is true, perhaps in even more exaggerated fashion, with our total symptom burden score. And we see, again, here, higher is worse, lower is better. And we actually see peaks and valleys in the symptom burden score that correlate quite nicely with what's happening clinically with that patient as well. And then this is information, again, that our coaches can track as they work with patients over time. Next slide. And then we use these data as they come in to then guide triage of services. So, for example, with this particular participant, we were able to identify issues related to insomnia, integrative oncology or physical therapy needs. So we generated referrals around unmet needs related to nutrition. And then in this case, this particular individual is already working with psychosocial oncology, but we could understand some exacerbations of anxiety to help with agenda setting for a subsequent provider visit that I think this person found to be helpful. Next slide. Next slide. And again, in the interest of time, we'll go fairly quickly. So this is a fairly young program, but I think what's been quite gratifying is that we had to start somewhere. We're not heavily funded, and so we actually have a lot of volunteer coaches who are working with us, and we have a fairly extensive training program. They're all city IRB approved as well, that they go through, and they come with a variety of backgrounds. They take on a couple of patients each. We record all the calls. We do quality assurance, make sure that people are not practicing sort of outside of their scope, and that any issues that require additional clinical or expert input are escalated to be addressed as well. Next slide. And so far, our effective denominator is probably around, if you just look at the lowest two lines, we've had 21 graduates from the 6-month program. We have 23 actively being coached. So our effective denominator is around 45. And we have some attrition over time, as you might expect. Some individuals, because life is complicated, end up dropping out before they even start. And then a few have had some events over time that have caused them to discontinue their participation. With a 6-month program, I think that it's actually a really unique opportunity for intervention, because a lot of things happen, as we all know, unfortunately, in the cancer care trajectory related to disease progression, relapse, or other ways in which goals shift. And one of our goals is to really be present with patients throughout the entire trajectory so we can respond to those needs over time. Next slide. And this is just an honest reflection of where we are with adherence. I think that there's some room for improvement. What's actually been gratifying about this, though, is that I've done a fair amount of observational work with sensors previously, and it's amazing that when you actually have a program that people know that their data are being looked at and used by the team to guide the intervention, the adherence metrics really are driven, are driven way up. And like I look at that bottom line, there's the potential days worn for the Fitbits, and 92% is certainly higher than what we'd experienced in our prior work. So we're finding that the program's a nice way to actually bring in the data set that you can then potentially use for secondary exploratory analyses, as missing data otherwise is a big problem that complicates those types of studies. Next slide. And so far, we're finding, probably similar to other PRO work that's been done, virtually everybody is generating an alert among our effective denominator. And we're finding that we're able to use these alerts to generate a number of new referrals, about 30 referrals in total so far across our participants. Interestingly, I think that our population is fairly enriched for psycho-oncologic comorbidity. We do get some from our comprehensive cancer support program who are referred, and we have a lot of anxiety and depression alerts. That also probably reflects as well the under-recognized needs in our cancer patients around these issues. Next slide. What's been nice is that we have developed a formal qualitative interview at the 6-month time point. and participants have been very willing to have us share some of their quotes. And it's nice to know that we think that we're helping some get back to a good new normal as we focus on their health optimization over time. Next slide. So what is a digital biomarker, and can we envision a sensor-based health score? I think that Dr. Bonato has done a wonderful job helping us think about what that might look like. You know, I've approached this in a couple of different ways. I'll admit that I spent some time trying to do a lot of the primary data work, and then I sort of shifted my focus a little bit to saying, how can I just sort of stand up a program in some way, keep the metrics fairly simple, and then maybe we can now use this framework, because we know that the pieces are working pretty well, to begin to layer in digital biomarkers. So in some work that I'm not showing, I think as Dr. Bonato had shown, you can actually use sensors to estimate the visual analog scale, I believe is what he had shown from work done some years ago around rehabilitative function. We've done some similar work looking at our ability to estimate the actual promised physical function score simply using metrics from some of the wearable data sensors. And that was a different sensor, different study, but we integrated metrics like resting heart rate variability, respiratory rate, activity, and then some of the complex relationships between activity and physiologic metrics to basically come up with, via machine learning, a score that would approximate the self-reported physical function, and did a reasonably good job at that. So I think that that's sort of where we want to move this in the future, as we develop metrics that we can follow over time that perhaps are a bit more, a bit less missing data, and maybe even a bit more precise in terms of understanding physical function. Next slide. So a couple of lessons learned, and then I'll wrap up and we can go to the panel discussion. Next slide. So this is what I've learned in building this program so far. I think it's critically important that we listen to patients when we're choosing the PROs that we use in these programs. We've done a lot of sort of swapping in and out and iterative improvements over time that reflects that. I think it's been clear, we've learned this from our sensor data already, that meaning drives adherence. If participants feel that you're actually using the information that they're providing to you to help make their lives better, they're much more likely to actually fill out the PROs and wear the sensors, which makes sense. And I think it's a way in which we respect the participation of our patients. I show the navigation slide, the different pathways that we've built into the different services that we work with. They have been really hard to build, to be quite honest. But I think that they work well now. And so there's a lot of negotiation back and forth to find out kind of what the different capabilities and needs are with the different services that we work with, and which really are the right types of patients to work with those services. We've learned that over time, continuing to iterate on it. But I think that kind of thinking about each individual pathway on its own is really pretty important. And then honestly, this is an area where we still need to get better in. We have to minimize disruption and we're talking about how health reflects our lived experiences of patients at home. If they're spending all their time doing surveys and wearing Fitbits, that may interfere in some way. And so I think, that the proof is in the data in some way. We can see where our adherence metrics fall off, and we're continuing to get information from participants at that 6-month mark. We're going to really try to, I think, slim down and tailor some of these assessments to really minimize participant burden to the extent possible. Next slide. I don't think I'm really going to go into this, but I just want to kind of put a couple of graphics out there for you to think about. If we have a framework in which coaches, or you can come up with a different name for that type of a role, are working with participants on health optimization or tracking PRO and patient-generated health data over time, you can actually think about different use cases in which this type of a data gathering system could be quite helpful. And I'll just kind of put a few out there to leave with without really going into a lot of detail about them. Next slide. So one possibility, we can actually go to the next slide as well. So one possibility to think about digital therapeutic companions. So if you think about particular medications that have a challenging toxicity or side effect profile, you're looking to, on the one hand, maximize adherence, but on the other hand, really address a lot of the important symptomatic needs that an individual experience. This type of a data gathering system could potentially be helpful for that. Next slide. If we think about navigation of patients, this is something else that I'm doing at the Cancer Center. Really won't get into a lot of detail now, but as you think about both social and clinical determinants of health, gathering these from EHRs, abstraction, and other ways. Not everybody probably needs the type of services that I've been describing, but you can begin to segment out those patients who you think are probably at highest risk of having challenges achieving their optimal vision of health and begin to deliver those services in a targeted way towards them. Next slide. And then finally, this is work that I'm doing in a separate project with ASH, but we're thinking about real-world data network development. And so we need to find a way, and other real-world data programs do as well, thinking about how to really bring in the patient experience. And so again, I think that any of those approaches are usually beset by issues with implementation and data missingness. But if you have a sort of a human touch oriented program that participants find meaningful and engaging, this is a way to try to bring in methods to optimize adherence and collect data on other areas of interest. Next slide. So I'll stop there. I understand that the talk was pretty conceptual, but I'm happy to answer questions that come up and think about ways in which this might stimulate further thinking around wearables, digital biomarkers, and related topics.
Well, thank you so much. Wonderful talks and so much to think about. We have a couple of guest panelists. Dr. Don Dizon is a professor of medicine at Brown, and we know him as the chair of our Digital Engagement Committee. Don, do you want to comment a little bit about your impressions of what you learned today that maybe seems striking or different than maybe what you were thinking about in this realm coming into this symposium?
Sure. So, I mean, I think actually one of the richest areas for investigation is the whole notion of using biomarker data, or actually using sensor data or wearable data to try to find a novel biomarker that tells us something that's clinically significant. And certainly, I think the work from PMNR is really informative of what we could do in oncology. These biomarkers are, if you look at the cardiovascular space, for example, they're doing their own work, but it's for their own field. And I think this kind of sort of synthesis from other areas of medicine is going to be where we learn from each other and learn how to go forward. The other thing that I thought was really interesting with Dr. Wood, your presentation, is that you're actually highlighting the importance of a physical intervention to couple with biomarker sensors. People need to know. I think what's interesting and almost provocative is it may not be enough for the sensor to be the intervention, right? That the sensor is a way to inform another intervention. For you, for example, the coupling of PRO data with sensor data, you are trying to encourage change because you're also coupling that with personal coaching. So the question then becomes, what is the intervention that's being done here? And I think that's a really provocative question, right? Is it the coaching and you're giving them more tools so that they can influence the outcome? Or is it a more passive thing? Because if the coach getting the information is the important step, then it kind of doesn't matter what the sensor is. You could do an Oura Ring, you could do Fitbit, because what you're talking about is really capturing rich, sensor data so that the coaching can take place. But I thought it was, it's far more complicated. But I think we are still in this very, very much in this development discovery phase, and I think that makes it really rich.
Thanks, Don. Dr. Bonato or Dr. Wood, do you have any comments about what you just heard, particularly about the composite nature of the whole enterprise and what that means?
Bill, you want to go first?
Sure, I'm happy just to make a quick comment or two. First of all, thanks for the reflection. I appreciate that, and I think that's been one of my lessons learned as well. That to me, it's that intervention, the human part of the intervention, that really makes it sort of sticky and helps participants remain engaged throughout the course. I was struck by other larger, digital health studies in other areas outside of oncology where there's incredible amount of attrition after an early sort of enthusiasm after individuals wear a sensor for a week or two or a month. I'm not sure what the magic number is there. And this is, one way to potentially address that. That having been said, from a methodological perspective, the question is really what is actually driving outcomes if positive outcomes are seen. So we've been thinking about that as a team a little bit. And one idea that we had potentially was to, do a study where we would potentially compare sort of the whole package to perhaps, giving participants a sensor in the dashboard, but not having any of the coaching, and seeing if we're really, what that looks like, both in terms of adherence and in terms of outcomes. And then, I'll just say briefly about your idea about kind of other areas of medicine. I love that. And maybe I'll kind of kick this back to Dr. Bonato. I know one of your first slides, Dr. Bonato, was around cardiorespiratory fitness, which is kind of an area that I've been doing, a lot of thinking about too. And, it's been an area that's been integral to various parts of medicine for some time, and now it's sort of clearly taking off in the consumer space as well. We don't use that as much in oncology, but maybe we should. We use performance status all the time. And so, is there a different way that we should be thinking about function, and is cardiorespiratory fitness, something from the area of medicine that we could potentially, bring in, or other metrics like it? So I'll stop there, but thank you for the comments.
Yeah, I will echo it. I think, Don, you really nailed it, right? And so we are at a stage where we're looking both at discovery opportunities as well as data that we want to leverage for the purpose of improving our ability to deliver interventions. I feel like across the field, we're still relatively naive and ineffective in terms of behavioral interventions, which are often very, very important in the context of dealing with chronic conditions. But also, as we are collecting data, as Bill was mentioning, we are discovering associations that we thought were there, but we weren't really able to measure. I noticed a comment in the chat, for instance, about sleep, right? And in our field, when we look into motor retraining, we know the relevance of it for consolidation. And we know that as a concept. We know the association between, for instance, proficiency and learning new motor patterns. But we know that more theoretically than practically. And then in the clinical practice, we don't have the tools to actually use that scientific fundamental knowledge that we have developed over time, because we don't have measures of it. And so I feel like we have an opportunity both to discover as well as to design better intervention by using this technology. But we are still provided with a better car, if you will, right? We still need a driver, right? And so it's not as if, we're just getting the data, everything is going to be resolved, right? You need the pilot, and the dashboard might be complex, and it's good if all the pilots have a complex dashboard, because you need that information to fly safely, right? And as I said, we are going to be able to deliver better intervention if we use that dashboard properly.
Wonderful, wonderful. Well, I think that we've run out of time for our symposium, but it has been extremely rich, and I very much appreciate Dr. Wood and Dr. Bonato, you for being our plenary speakers, and Don for joining us in our panel discussion. Thanks again. There's so much more to talk about, and we'll have more to follow up on. But Dr. Henry, do you want us to take us to some of the new adventures that we have, new ideas coming forth from our committee?
Sure, thank you. So I just wanted to thank again the speakers. That was lovely, thought-provoking talks from both of you. And I think as we go forward, especially as we're thinking about things like how to measure chemotherapy-induced neuropathy, what can we do in geriatric oncology? These are all very important things as we think about how to incorporate wearables and sensors and other types of data. So thank you again. We want to switch now to new concepts, and the slides are going to be a little bit out of order because I don't actually see that Melissa Accordino is on the call. So if you are, please speak up or send us a note in the chat. So I was going to go forward, I think it's 2 slides or 3 slides from here to the 2013. There we go. So we're going to talk about iCheckIt. So this is a clinical trial that you've heard about before. It's been in the works for a while now, and we're finally almost at activation. So we wanted to bring it back to everyone again. And so I'm going to turn it over to Dr. Gunturu, who's going to describe the trial, recap sort of how it ended up at the end, and let us know what's next. So go ahead, Dr. Gunturu.
Thank you very much, Dr. Henry and Dr. Fish. And so this is the study we talked, as Dr. Henry mentioned, and this is iCheckIt immune checkpoint inhibitor toxicity, which is approved and soon ready to be enrolled in open in summer. So let me walk you through what the proposal is and what we're trying to achieve and our why for this proposal. So I don't think I have control over slides. So next slide, please. So the main question that we're asking is, would you like to have a risk prediction model for the immune checkpoint inhibitors and immune-related adverse events? Because we're using more and more of these immune checkpoint inhibitors. It was initially in metastatic and advanced setting, and now it is moving into adjuvant and neoadjuvant settings in the recent AACR, ASCO, like every meeting you go to. So you're seeing in every disease site. So this is moving to earlier levels. So next slide, please. So our question is what we can do better while people are living longer with these newer treatments, how we can make their lives fuller with the better symptom control and quality of life. So the primary objective of this study is to develop and also to validate a risk prediction model based on non-hematological grade 3 or higher IRAEs in people receiving immune checkpoint inhibitors in the solid tumors. Next slide, please. So the secondary objectives, we are going to measure the chronic low-grade toxicities along with other toxicities. And as we talked about patient-reported outcomes and CTCAE toxicity over time, over 12 months. So this includes the incidence of any grade non-hematological and grade 4 hematological IRAEs. And people, as you see, more and more of them are having endocrinopathies and needing replacements for the rest of their lives, or chronic toxicities with a rash or other changes that is affecting their quality of life. We also would like to track the patterns of treatment IRAEs and toxicity resolution. So our translational objectives led by translational chair Dr. Lucas Govan and Dr. Nicole Kuder is looking at the cytox score, which is a measure of 11 different cytokine levels prior to ICI, and also one cycle to predict the development of IRAEs. So this will be a huge biorepository for the tissue and serum for any investigators looking at the predictive and prognostic IRAE risk. So this would be a dream come true for any investigator with this big study. So next slide, please. If you don't remember anything from this list, the main thing I would like to take home with is we're looking at the chronic toxicities and patient-reported outcomes in this study as the secondary objectives along with the primary. Next slide, please. Eligibility is pretty open, and this is for patients and solid tumors receiving immune checkpoint inhibitors as a standard treatment, monotherapy, or combination immune checkpoint inhibitors. We excluded chemo, bio, and targeted therapy to keep this as a homogeneous to come up with the prediction tool. They can have prior ICI therapy, but must not be have discontinued because of the IRAEs, and also should have recovered from the side effects of prior therapies for treating physician's discretion, which we clearly outlined in the protocol, and able to complete the patient-reported outcomes in English, Spanish, or French. Next slide, please. I want to take this moment for people who are interested in knowing what we included for the factors for risk prediction model. Our statistics team, led by Dr. Unger and rest of the statistics team, put this beautiful plan of patients in two-step approach. One is trying to develop a tool to predict what are the factors that would influence the IRAE prediction. And in the same study, taking this into validation. So this is a two-step study. So the first step is including 1,200 patients and 800 patients for the validation. And we are looking at the demographics and the history, which you see here, including age, sex, race, performance status, BMI. And we're also including history of autoimmune diseases and prior exposure to immune checkpoint inhibitors and cytotoxic therapy. We're also taking into account the patient-reported outcomes, as was mentioned by Dr. Wood and Dr. Bonato, is making sure that we are getting information from the patients, not just saying what we should be doing. And we're also including the labs for assessments too, including ANC, hemoglobin, and ACTH, cortisol, thyroid levels. Next one, please. So this is our accrual goal is 2,000 plus patient, 2,062. And this would be, the one thing I wanted to emphasize is this would be 5 times evaluation. So this is not a big lift for our patients or also for our sites too. That this would be 5 times evaluations at baseline, week 4, 12, 24 and 52. That would be the evaluations, and blood draws will be at baseline and after the first cycle, and if they develop any IRAEs at that time. This would be also easy for ANCOR, the assessment, and also for accrual goals too. So I'll stop there, and I would like to thank this whole team who got this through the close to the finish line of opening soon. And this takes a village, and I invite anyone for questions and my team.
Yeah, thank you so much, Krishna. So as mentioned, this is a trial that we have coming up that will be open soon. We're very much looking forward to it. It's been a while in the works. I want to encourage all sites to please consider opening this. It's open across multiple tumor types. The only requirements are that you're not getting chemotherapy along with immunotherapy, and that you're not actually enrolling the patient in a treatment trial of immunotherapy. So if you have any questions, please feel free to reach out either now or once the trial actually activates sometime this summer. And so if you can go back to the slide before her slides, Dan Hertz is going to, no, the one after that. Dan Hertz is going to tell us very briefly about a survey that is out there circulating.
Yeah, so this is an update to a concept that we started talking about a year, maybe over a year ago. So I don't have time for the whole background, but suffice it to say that we know for sure that DPD deficient patients, many of whom carry DPYD genetic variants, had high risk of severe and potentially fatal toxicity from fluoropyrimidines. Pre-treatment DPYD or DPD testing is standard across a lot of Europe, but is not really used much in the United States. So the purpose of our survey was to understand how much DPD testing is being used and what are the major barriers to using it, so we can figure out how to design a trial to demonstrate the clinical benefit of pre-treatment DPD testing. So as Dr. Henry mentioned, our survey is out in the field right now. It was sent to I think about 250 breast and GI medical oncologists who practice in the United States through the SWOG committees. These are results from a couple of weeks ago. We're up around 45 responses now. So a little less than a third of medical oncologists have ordered a test prior to treatment. About a quarter agree that it's useful to inform treatment. And then we asked our sort of most important question was, what are the most important factors for not testing? And as we saw in our single site survey before we did this, the low prevalence of DPD deficiency and the lack of clinical practice guidelines that support pretreatment testing are the most common responses. And there are a lot of clinicians that have some concerns about a lack of evidence, potential for costs, and a potential for decreasing efficacy if we do reduce treatment in DPD deficient patients. So as I mentioned, the survey is out in the field. We're going to give respondents another couple of weeks, and then we're going to look over the final data to figure out whether we can run some kind of prospective trial. Unclear if that would be a randomized controlled trial comparing genotype guided treatment versus standard of care without genotyping, or perhaps some kind of single arm trial of just genotype guided treatment to see what the decrease in toxicity and potential decrease in efficacy look like. So still a concept in development, but we're starting to collect the survey data that we need to design a clinical trial. And I hope to bring something back to the committee probably at the fall meeting where we have a better idea of how we would design a study.
Thank you so much. And I encourage everyone to please go ahead and complete that survey if you received it. I think this will be really important information moving forward. So if we move one slide backwards. There we go. And Dawn, are you able to talk?
I don't know, can you hear me?
Yes.
All right.
It's a miracle. It's only taken an hour and a half to figure out how to get that to work.
You broke in.
So, yeah, so I just got a text from Dr. Accordino, who got caught up with the urgent patient issue. So just as a bit of background, because I'm not sure what's been presented in the past, four cooperative groups all had clinical trials looking at ways of using some type of compression therapy, cryotherapy, or combination of them to see if it would be effective at controlling or preventing chemotherapy-induced peripheral neuropathy. So we joined forces to develop a single protocol that will be developed probably between now and the next meeting, looking at a device that was developed by Richard Paxman, from the Paxman scalp cooling fame, that will be randomizing patients to a combination of cryotherapy, which is cooling, versus some type of compression therapy, versus a combination of the two. And we'll be looking to prevent chemotherapy-induced peripheral neuropathy. I don't know if it was just one slide that she had, or...
Yeah.
Yep.
Okay. We have an ongoing trial that is comparing a light compression to which is our control, to a tighter compression, which is a tight glove, which is more like a compression stocking, to cryotherapy that is looking for the winner. The endpoint was met, and so that is going to inform the design of the ultimate randomization for this trial. So more to come.
Thank you very much. I know that it's definitely a work in progress. This is very early in development. And so, we definitely look forward to hearing more about the plans as they evolve.
Great. Well, I think we're up against the end of our time slot. We wanted to thank everybody for participating in our spring virtual meeting. I think we've learned a lot here about wearables, and it's nice to hear about these new concepts, and particularly the iCheckIt study that's about to start. We ran out of time to go over some of our active studies, and there's lots more to talk about. And we invite you to reach out to us by email if you have ideas. And we look forward to our committee meetings moving forward. So thanks again and enjoy the rest of the SWOG meetings.
Thanks everyone for attending.